Hello and welcome to TB101, a special edition training from We Are TB and the National Tuberculosis Coalition of America and facilitated by TB fighters. My name is Tori and I will be your host tonight, and with me are two of our very special guests. First up, we have Dr. Kelly Holland, a family physician in Massachusetts who treats tuberculosis patients. He is also the tallest ever person in his family and has a small but dedicated fan club from last year's Massachusetts group at TB Hill Day. And I have a feeling that group is going to grow after tonight. Say hi, Dr. Kelly.
Hi, guys. Glad to be here.
We also have Amy Painter with us tonight. Amy is the TB Program Manager of South Carolina and the current Secretary of NTCA's board. And just 2 years ago, she had all four of her daughters in college at the same time. I just met Amy tonight, and I'm so excited to learn more from her. So say hi, Amy.
Good evening, everybody.
So we have two things before we get started that I want to go over. The first one is super important. I mentioned that this training is brought to us by We Are TB, an amazing organization of TB survivors and advocates. In addition to their amazing advocacy work, We Are TB runs confidential support groups for TB survivors in English and Spanish. And I'm going to pitch that to Dr. Kelly for a second to tell us how you can find the information on that.
Yes, so We Are TB does have these support groups. So if you just go to wearetb.com, there is a place to enter in your information, which again will only be shared with us confidential within the group. And then we can pass on to you the link for our support spaces, which are currently in English and Spanish. If you have or know someone who has a different language preference, they can enter their language preference and we can try to match them with a tuberculosis survivor who speaks the language in which they're comfortable.
Thank you for that. And the link for We Are TB is in the description of this video, and I'm sure we will share it some more. The second thing is way less important than that, but it's just a note about how this session is going to work. Kelly and Amy are going to walk us through their content, and if you have questions for them during that training, put them in the chat of the YouTube live stream. Our amazing live stream team is going to gather them up throughout the session, and we'll do a Q&A at the end. I think that is everything from me, so I'm going to pass it over to Kelly and Amy.
Great. Well, thank you all. I'm so grateful to be here with you and realize that all of you are probably interested in this movement and have come here for different reasons, but you've already done the most important thing, which is to realize that a tuberculosis disease can be cured and prevented, and so it should be cured and prevented. And we're going to advocate to make sure that that happens. Now, to do that effectively, it is important to know some of the background and some of the details of this disease, and so we want to give you some of that information, but also know that you've already done the most important thing, which is realize that this is something we can do and we must do. So when I typically work with medical students, I will start with a case, and I think that's always helpful because when we're getting a lot of details and science, it's important to keep the person affected front and center. So I'm going to start us off with a case, and then our colleague Amy will take over and give you some of the good details about tuberculosis that can help you when you're trying to make an effective argument or a productive discussion with either a legislator or other folks who we're going to meet later on in Hill Day or other people you just encounter. So we'll just dive right in to the case. And this is a real case that was seen in my health center north of Boston. Essentially we had a 33-year-old healthy male came into our office because that morning he had coughed up blood. And I'll just say one other thing is that every tuberculosis patient or every person affected by this disease is different and has a unique story, but there are similarities that run through this. And so this is a pretty typical presentation for tuberculosis in the United States. And so as we're going through later, just keep some of these things in mind. So this individual had no other medical conditions, did not smoke. When asked more about any other lung problems, he said, well, he was treated for pneumonia 2 months ago and was told 10 years prior to this that he had a positive tuberculosis skin test. And so what will often happen in a situation like this, or what we hope will happen, is that in addition to a good exam and some more history, someone will think that this deserves to get an X-ray. So here is his X-ray. And for those of you who don't spend an awful lot of time reading x-rays, this is, you can see the L up there in the top corner. So this, what you're on the right side of your screen is actually the left side of the patient. But since probably most of us don't spend a ton of time looking at these, I have one of his x-rays that was done for a different reason 3 years earlier. And so if you look in the one that was done in 2014, you can see my arrow. On this left side here, there is some more white and some more haze over here that's not present in the original one. And so that led the team to be nervous that there was something going on in the lungs. And then because they didn't quite know what this could be, they ordered a CT scan, also called a CAT scan, which is right here. And typically on these type of tests, air, which our lungs are mostly air, is dark colored or black. And so you want to see mostly black, but in this case, you can see here, this is a horizontal view as if you're looking up through his feet. So you have the heart right here, this is the spine, and all of this is not supposed to be here. And these holes are actually what we call cavities, or just actual holes in the lungs. And then on this one, this is another front view. And this is a different way of looking at those holes surrounded by inflammation from the infection that was causing this. And so again, what we hope will happen is that someone will think about tuberculosis and get a sputum test, which we used to call, when I was growing up, a loogie, or phlegm. And so in this case, the emergency room physician asked him to cough up some phlegm, and they put it on a slide, which we call a smear. And this is it right here. They add a special stain to this sputum smear, and in the presence of tuberculosis, this special stain glows fluorescent green. So what you're looking at there are the actual tuberculosis bacteria that were in his lungs causing all that. So as Amy goes through a lot of the important details about this bacteria, I want you to think about this, and then I will come back in and we'll return to talk about sort of what happened next and what we hope happens whenever somebody is diagnosed with tuberculosis. So I'll pass it to my colleague, Amy.
Thank you so much, Kelly. So let's talk about TB, what TB is and what TB is not. So TB is the #1 infectious disease killer worldwide. This was surpassed briefly by COVID, but now the spotlight is back on TB. TB is a disease that can affect anyone. Anyone who breathes could be infected with the TB bacterium. TB is a disease that usually affects the lungs, but can actually affect any part of the body. And TB is spread when a contagious person coughs, sneezes, speaks, or sings. TB is preventable, meaning that if we treat TB infection, we can reduce our lifelong risk of developing TB disease. And TB is curable, but critically important is our first bullet here, where TB is the #1 infectious disease killer worldwide. Far too many people are still dying from TB disease. What TB is not? TB is not a thing of the past. TB case rates continue to rise. TB is not spread by sharing food or utensils, and it's not spread by kissing, shaking hands, or by sexual contact. So let's talk about the difference between TB disease and latent TB infection, also called LTBI. With TB disease, there are many active bacteria in the body, and I explain this as the bacteria are being awake in the body. With TB disease, a person can infect others if the disease is in their lungs or in their larynx. The larynx is also called the voice box. With TB disease, a person may feel sick, and we'll talk about these symptoms shortly. With TB disease, a person usually has a positive TB screening test, and that's either the skin test or the blood test. And we say usually because if a person has overwhelming TB disease, their body may not be able to respond to the screening test. And when diagnosing TB disease, this is one component of the diagnosis. And people with TB disease need treatment for cure. With LTBI, there are fewer bacteria in the body, and I use the description of saying that these bacteria are asleep in the body. LTBI is not contagious and cannot be spread to others. And with LTBI, a person does not feel sick. With LTBI, a person has a positive TB screening test, either that skin test or the blood test, and we still need to treat LTBI to prevent progression to active disease. Let's talk about the types of TB disease. We have pulmonary TB disease and extrapulmonary TB disease. And with pulmonary TB disease, this most often includes the lungs. This can also include the larynx or the voice box, and it can include the lining around the lungs called the pleura. Individuals with pulmonary TB disease are often infectious, and others around them can be at risk of breathing in the TB bacteria. With extrapulmonary TB disease, this includes all other parts of the bodies that do not involve our respiratory system, and individuals with extrapulmonary TB are generally not infectious. The symptoms of TB disease when it's in the lungs or in the pulmonary respiratory system are cough that lasts longer than 3 weeks, and you can sometimes cough up blood. You'll have fever and chills, you'll be extremely tired, have night sweats, and weight loss. When it's extrapulmonary TB disease, if it involves the lymph nodes, your lymph nodes can be swollen. If you have Pott's disease or TB of the spine, you're having back pain. If you're having TB of the gastrointestinal system, you can have abdominal pain. When you have TB of the brain, you can have confusion or headache. And then you can have chest pain when you have TB of the heart. Also important to note with extrapulmonary TB disease, a person can still have weight loss, night sweats, fevers, and tiredness. How do we test to see if the TB bacteria has entered the body? There's 2 types of tests out there. You have the tuberculin skin test or the tuberculin skin test or the TB skin test, or the interferon gamma release assay called an IGRA. Some people refer to it as an IGRA, but that's your TB blood test. With the TB skin test, this is your lowest cost method. It's the oldest, but still very reliable. But this test is subject to interpretation. So the provider reading the skin test should be looking for a hard knot under the surface of the skin where the skin test was placed. This is called induration. Untrained providers may measure redness at the site of the skin test placement, which is an incorrect way of interpreting the skin test. A skin test requires 2 visits, one for the placement of the test and then a follow-up reading of the test in 48 to 72 hours. This test can be falsely positive if the person has been previously vaccinated with the BCG vaccine. This is not a routine childhood vaccine in the U.S., however, it is given routinely in countries with increased rates of TB. With the IGRA, there are 2 FDA-approved tests. You have the QuantiFERON TB Gold Plus, or QFT, and the T-Spot. The TB blood test is more sensitive and specific than the TB skin test. This test only requires 1 visit for that blood draw, but results can take up to 7 days. And the blood must be processed within 8 to 30 hours after collection. Important to note here that there are no false positive results related to the BCG vaccine. So what does a positive TB test mean? It simply means that the TB bacteria have entered the body. With just the TB test result and no clinical evaluation, you shouldn't say you have TB just based on the test. There's still a lot of misunderstanding between the difference of latent TB infection, or LTBI, and active TB disease. So what happens after a positive TB screening test, either that blood test or that skin test? The next step is a chest x-ray. Once the chest x-ray is complete, you should be seen by a provider for a clinical evaluation. If you have a positive TB screening test, a normal chest x-ray, and no symptoms of active disease, the provider will diagnose you with LTBI, or latent TB infection. If you have a positive TB screening test with symptoms of active disease, further evaluation is needed, such as sputum collection. The TB screening test result, the radiological findings, the assessment of symptoms, and laboratory studies are all used together to make a diagnosis of TB disease. So how is TB transmitted? Again, it is transmitted through the air, and it's transmitted when a contagious person coughs, sings, sneezes, or speaks. TB is not transmitted by sharing food or utensils, by drinking after someone, by kissing, or through sexual contact. So let's talk about risk factors for TB. You want to think about risk factors in two categories. The first category being persons who are at high risk of being exposed to TB, and the second category being the personal risk that put a person at greater risk of developing disease if they become infected. So in the first category, what puts a person at higher risk of being exposed to TB? Obviously, if you have contact with someone with infectious TB disease, that puts you at higher risk. Healthcare workers who have clients who are at increased risk of having active TB disease. Employees of high-risk congregate settings, so think of these settings such as prisons or long-term care facilities, and current or former residents of these facilities. Infants, children, and adolescents exposed to adults who are at increased risk of TB disease, and then of individuals who are born in or travel frequently to countries where TB is common. What personal risk put a person at greater risk of developing disease if infected? So persons living with HIV, especially if their CD4 count is low, persons on immunosuppressive therapy, such as chemo, anti-rejection medications following an organ transplant, and certain other medications. If you've been in close contact with someone with TB disease and breathed in that TB bacteria, you are at highest risk of developing TB disease in that first 2 years after becoming initially infected. Persons with uncontrolled diabetes have a greater risk of developing disease if infected. Persons with low body weight, children less than 5 years of age in this group can develop disease rapidly if infected, and this age group also has a higher risk of severe complications such as TB meningitis. Other personal risks include lung condition called silicosis, kidney failure, cancers of the head, neck, and lungs, leukemia, inadequate treatment of latent TB infection, meaning never being treated for LTBI or not completing your regimen for LTBI, removal of part of the stomach or weight loss surgery, and substance abuse, including drugs or alcohol, and smoking. Let's go over some of the data of TB in the United States. When you look at this data from the early 1990s until 2024, you see a decrease in your cases and incidence rate. And then following the COVID-19 pandemic, you start to see a rise of cases again. The key takeaway here is that in 2024, the United States had 10,388 cases. This is the largest number of TB cases in the U.S. since 2011. When you look at this heat map of the U.S., you see that the highest number of cases are seen in California, Texas, and New York. This is depicted in the dark blue. These states saw over 1,000 cases. The key takeaway from this slide is that from 2023 to 2024, 36 states had an increase of TB cases from the year prior. Let's look at data related to race and ethnicity. Here you see a similar distribution of Asian as compared to Hispanic Latino, and the key takeaway here is that in 2024, when compared to 2023 data, TB case counts increased amongst all racial and ethnic groups except in persons identifying as white. When we look at data by age group, the largest percentage of cases in 2024 is in the 25 to 44 years of age. The key takeaway from this graph is that in 2024, 5% of TB cases were in individuals less than 15 years of age, and TB is most detrimental in this age group. When we look at this graph, we're looking at TB incidence rates, and if you look at age 65 years of age and older, we saw that 1 in every 100,000 people in this age group were diagnosed with TB in 2024. When you compare that group to the 0 to 4 age group, you learn that 2 in every 100,000 people were diagnosed with TB in 2024. So what role does public health play in TB? Well, it's a critical one. TB requires that clinical evaluation. It's necessary to determine if a person has LTBI or disease. This requires, as we've talked about in the previous slides, your screening test, your symptom evaluation, could include some radiological studies, sputum collection, and other laboratory studies. It could require obtaining documentation from other providers and asking about other health conditions. And in public health, these services are provided by nurses in conjunctions with physicians or nurse practitioners and PAs. And majority of these services may be provided in a patient's home. Public health has not been looked upon favorably in the recent years, and this poses a safety risk to our providers. Case management activities. When a patient gets reported to the local health department, patients are assigned to a provider who monitors their care in response to therapy for the entire course of treatment. And again, this is predominantly done by nurses, but this includes looking at the social aspects of the patient. If a patient is on home isolation, do they have the assistance they need in order to provide their groceries or to buy their groceries? And public health nurses often spend money out of their own pocket to meet the patient's needs during those periods of home isolation. Medication delivery and administration. So TB disease is treated by directly observed therapy, or DOT, and this means that every dose of medication taken is observed, and if a patient is doing well on the directly observed therapy, this may be switched to video directly observed therapy. Public health staff also do contact investigation, so that's your identification, screening, and testing of individuals exposed to persons with active TB disease. If a person has infectious TB disease, we want to test those persons with whom they've been in close contact with during their period of infectiousness. And based on when a person with TB disease first started having symptoms, this could include going back 6 months in time. And it's hard to remember what we had last weekend for dinner. We're looking at who they live with, work with, who they go to school with or church with, and what they do in their social network. And then public health also does data collection and reporting. So state case counts are required to be reported to the CDC using a standard form that de-identifies the case on a person level, and data collected is used for outreach activities. Next slide, Kelly. Thank you. So public health faces a lot of challenges. One of these challenges is federal funding challenges. States with lower number of TB cases may only be able to support their state TB services with federal funding, and funding is critical for sustainability. We face medication shortages and pricing challenges. Medication shortages could impact our ability for TB cases to complete a medication regimen. And if we are holding critical drugs to treat TB disease, this could impact our ability to treat LTBI. And pricing for drugs in recent years has put already strapped public health programs, it's put a burden on us to determine where we cut costs in other areas. We have staffing issues. This is occurring throughout the United States. Limited state funding for TB services and reduced federal funding equals a reduced workforce. Burnout post-COVID is real, and healthcare workers are exiting their field. And training of TB staff takes a minimum of 3 months due to the complexity of services we provide. Diagnostic issues include the inability of us here in the United States to get the Gene Expert Ultra, and our current testing methods are rapidly becoming antiquated compared to what is available outside of the United States. We spoke of federal funding challenges. This graph depicts fiscal years over the last 20 years. As you see, in 2004, the amount of federal funding did not equate to the amount of work being done. Funding increased and then decreased, and now is seen as level funded. And from this graph, you can see that level funding is essentially a decrease in funding. During a recent survey of federally funded programs, 62.5% reported that at least 50% of their budget comes from federal funding. In this graph, you can see the price increase of isoniazid or INH. Your red line equals your isoniazid 300 milligram tablets, a 100 count bottle. The green line is showing you isoniazid 100 milligram tablets in an 100 count bottle. And then the blue line is showing you isoniazid 300 milligram tablets in a 30 count bottle. So states went from paying mere dollars per bottle with Teva as a manufacturer to an excess of $300 a bottle for 100 tablets of isoniazid 300 milligrams when a new manufacturer came on the landscape. This manufacturer has shifted yet again within the year, and public health is having a hard time keeping up. When we talk about staffing issues, about 19% of federally funded programs had to reduce their workforce by greater than or equal to 40% due to delays in receiving their full federal funding award. Due to the changing landscape of public health, 48.3% of respondents to a recent NTCA survey expressed concern about their safety or the safety of that of their staff. And public health has been through so much in the last 6 years. On this same NTCA survey, 53.4% of respondents reported that they or their staff have faced mental health challenges associated with their work. We talked about our inability to move towards the Gene Expert Ultra in the United States. During this last year, the United States also faced quality control issues with testing of pyrazinamide for drug susceptibility testing. Our key takeaways: TB is transmitted through the air. Anyone that breathes can get infected with TB. There are 2 types of TB, and this is important: TB disease and latent TB infection. A positive TB screening test, either that skin test or blood test, does not necessarily mean that you have active TB disease. And cases of TB in the United States have been increasing since 2011. As Kelly said, TB is preventable and TB is curable. Thank you, Kelly.
Well, thank you, Amy, for that very detailed and very thorough background, not just about the mycobacterium, but about how our public health and our healthcare system helps to make this curable and preventable. So now we're going to return to our initial case. And if you were somebody who watched television in the 1980s, this is that moment where I say, not only am I a TB clinician, but I am also a former TB patient. So that X-ray was my X-ray. That sputum was my actual sputum, my CAT scans. And I had active pulmonary tuberculosis. And this, what you're looking at right now, is my treatment. So when we talk about the standard treatment for drug-susceptible tuberculosis, this is it. And if it looks like it's a lot of pills, that's not your eyes deceiving you. This is not 5 days worth of medicine. This is 1 day of medicine. This is 16 pills that I took every morning with the support of my public health nurse and, of course, my wonderful family. I had a love-hate relationship with these pills. I loved that they were curing me, and I didn't like how I felt. These pills, as you could probably imagine, it's a heavy weight in your hand, and they have side effects. Some of them are quite old. They're very necessary, but it's not easy. And if you could see my arrow, this one right here is that pill that Amy pointed out, the isoniazid, which has gone up in cost from just under $1 to $300 for a single bottle. And not because the medicine has been improved or researched or anything, it's just a different manufacturer, and it's a big problem. But these meds saved my life, and as we all on this call are going to fight, that anybody who has this disease needs to have access to these medicines. This is how you get cured. And so, I think about what is the progress we've made in these medications. Well, this is me in 2014 in the hospital. This is actually my mom In 1968, she had active pulmonary TB before I was born. And although I don't have her medical records and she couldn't remember exactly, from what she told me and what she remembered, the regimen she took in 1968 was very similar to what I took 46 years later. And so, and it's not because the regimen is perfect. We have drug resistance, we have multi-drug resistance, we have extensively drug resistance. And there are very dedicated scientists who are working the treatment for multi-drug and extensively drug-resistant tuberculosis is getting better. And we need to keep those trials going because tuberculosis seems to always be one step ahead of us. And it's the research and our advocacy that's going to keep this pushing forward. Because 46 years from now, I don't want a patient that I see to be getting the same medicines that I did or that my mom did so many years ago. And the way that we're going to do that is if we get increased research and increased care and our work in advocacy. So we have our work cut out for us. But again, I'm so, when I started off and said I was grateful to be here, it's because I truly am grateful to be here. And it is because of these medications and the dedication of the public health folks who really helped me. So Amy mentioned contact tracing, which is where we try to, that part of the TB being preventable, it's we try to look at, hey, who are the people around this individual who has tuberculosis, and can we treat them in that critical time before it becomes infection to disease? So this is a picture of my son. He was obviously very close to me at the time when I was contagious and had active TB. And so he had to go on preventative treatment. I'm very thankful that he did. But the one of the main medications we use for treating latent tuberculosis infection, or the preventive treatment, is called rifampin, and that turns all of a person's secretions and bodily fluids fluorescent orange. So this is my son with his fluorescent orange booger. He is now 13 and gives me permission to use this photo with quite a bit of eye rolling and grunting, but still his permission. And so, you know, something else as we're thinking about what patients experience when battling tuberculosis, there is a lot of stigma around this disease. There's stigma around who gets it, who's at risk for it. There's also, people are very afraid of it, afraid to be around someone who's sick with this. And so people get isolated, especially that is painful when someone who is sick most needs to have the people they care about close to them. I'll never forget one of our We Are TB members saying that she always pictured if she got sick, you know, her family would be lovingly around her hospital bed, giving her support like they were for her grandmother who had cancer. And she looked around her hospital bed because of the infectious nature of TB, and she was all alone. And so that isolation is very difficult, and the stigma can be very difficult. I feel very comfortable talking to you all because I did not experience a lot of stigma. I have a lot of, I didn't lose my job or lose friends or have any mistreatment because of my disease. But unfortunately, both in this country and around the world, that is not the case for many people. And so that part of stigma, even people stigmatized towards themselves that they did something wrong, or a lot of guilt around potentially exposing their loved ones. So there are many challenges that come through with this treatment. So what do we need? As Amy pointed out, we all need air. Air is our shared resource. And so you may encounter folks in your advocacy who say, this is not something I'm at risk of. I don't need to care about this disease. And we can gently remind them that, first of all, a disease that is preventable, that is curable and can be prevented, should be cured and prevented, regardless of if someone is at risk or not. But if someone does not respond to that argument, you can let them know, hey, this is airborne. And we know what happens when airborne diseases are not treated. We've all lived through that. So we need newer medicines to keep up with how tuberculosis can evolve resistance to our medicines we have now. We need faster diagnostics, especially in the United States. There are new innovations coming out that can be used around the world, but not here in the United States. We need a tuberculosis vaccine. Amy mentioned the BCG, which is a vaccine that is given in many other countries. It is good for preventing tuberculosis in the very young, which is important because it can be very severe, as she mentioned, in those under 5, but it doesn't do much to help us as adults. And in order to get that vaccine, we need to support those trials and those individuals and institutions that are doing it. We need to support public health. As Amy mentioned, all the things that our public health departments do for us, especially those who are treating patients with tuberculosis. And we need to re-engage with the world and the CDC domestically for all this, because we all in the end need TB to be eliminated. So how do we get there? Well, you guys are here. We get there by collaborating together and creating a movement, and we also get there by empowered patients, which is why we have We Are TB and Somos TB, and because again, this is something that can be isolating and disempowering, but if we educate and lift each other up, then it can be empowering and engaging. And so I also, as I said in the beginning, you all have come here on your own journey, and it's something that I got here because of my experience with this. And many of you got here without having to have this bacteria in your lungs to get your attention, which I deeply admire. But as you're going and meeting your representatives, your senators, their legislative aides, their staff, their teams, they might ask you, why is this important to you? How did you get onto this? And tell them whatever is right for you and what's true for you. But I also want you to know that I don't want anyone to feel like they can say, well, I don't know anybody affected by TB, or I don't know much about anyone who's had it, because you all know me now, and you know my story, and you can say it. You don't have to say, oh, some dude on a webinar. You can say, my friend Kelly, because if you're here watching this and you care about this movement, then I am proud to call you my friend. And so you can say, my friend Kelly, I saw the holes in his lungs. I saw the pills he had to take. I saw his son on meds. And if that feels like that is something that could help you in your advocacy, I want to do that. And if you feel like you want to meet in person first, then when we're all gathering in DC, you can come tell me your name, and then we can make it official. So I'm going to pause there because we want to make sure we have time for questions. And I'll turn it back to Tori.
Yes, and thank you, Kelly, so much. So we are going to flip to our Q&A now. Love this picture on the screen now. So I think you should be seeing our 2 new friends on the screen. We are going to be joined for this part by Kate O'Brien and Donna Wagner. So, and I know all about them, but I have my notes and I lost the tab because I have too many tabs open. So we have our Q&A, and we have a lot of great questions that have come in, and we've got 2 more guests with us. So, and we are having a little bit of video trouble on our end. So, and we fixed it. Never mind. Live TV, guys. So please welcome Kate O'Brien. Kate is a TB survivor and advocate, and she is also who I want to be when I grow up. And I cry every time I talk to her, but in a good way. So say hi, Kate.
Hi. I'll try not to cry for the remainder of the call.
I will, so it's fine. We also have Donna Wagner. Donna is the executive director of the National Tuberculosis Coalition of America, and this year's TB Hill Day will be her 11th consecutive year attending since they had the first one in 2016. She also miraculously still kind of likes me, even though I send her 9 million emails a day. So say hello, Donna.
Hello. Thank you. Glad to be here.
Yes. So we have a bunch of really great questions in the chat. But Kate, we were chatting in the Zoom a little bit, and I wanted to touch on something that you said and hear a little bit more about it, because you were talking about how it feels very weird to listen about the public health perspective and knowing that there's people on the other side of it, and having those conversations is very strange. So I'd love to hear a little bit more about that from you to get started.
Yeah, sure. And, again, like I'm sure Kelly, I had a very similar experience to Kelly where I didn't experience a ton of TB stigma. I experienced a ton of like TB ignorance when I had TB. Like nobody knew like really what was going on. And it can be really weird having like a state, organization or a state, a state department coming to your house and or talking to you on the phone or coming to you and asking you questions like where have you been and who have you been with. And people have really varied experiences with state agencies, right? Right now I wouldn't get into it, but depending on who you are and the kind of life you've led and the people that you could have all sorts of experiences with other state agencies. And now, they're coming to your home and they're asking you all these kind of questions. And it can feel really weird. And, TB being stigmatized as well, it's just like, it can be a perfect storm. So like, good public health is when that's kind of acknowledged and they treat you well and they're asking the questions because they really, when it doesn't feel like, who have you been with? What have you done? Like, who else did you do this to?
Yeah, you're sick and you did something wrong by being sick somehow.
Yeah, and when it can feel, but it can also feel like, hey, this is really tough, and we just really need to make sure that everyone that could be exposed is getting the treatment they need. We need to make sure that there's not somebody out there who, like you, maybe, had a latent TB infection that's progressed to active TB disease because they weren't treated. We can get people treated a lot faster, people that you care about, that you're close to, and it can be that way. It just takes more time, more care, and, just thinking about the experience of the person that's been diagnosed with TB. And again, like, we see everything in our support group. So like, I've seen it go both ways, but the contact investigation that I had, I thought they did a pretty decent job, so it can really vary.
Yeah. And one thing that we've heard about in one of our other conversations was it's probably hard to convince people that, like, I know that you don't feel sick, but you have to take these horrible medications that are going to turn everything that comes out of you orange for some reason, even though you don't feel sick, and you have to do it to keep everybody safe. Like that's a tough sell. So thank you for sharing a little bit about that. And we actually do have a question about that. The question's from me, it doesn't really count, but why does it turn you everything orange just from a science perspective? Similarly, why does the bacteria glow?
So I can tell you that. So it glows because there's tuberculosis is not just a standard bacteria like an E. coli or it's a mycobacteria. So it's got this funky coating to it that's called mycolic acid. So they created this stain that in the presence of that will fluoresce under the microscope. And I'll leave it at that so I don't get myself into too much trouble getting out of my own depth for the biochemistry. And why it turns you orange, it's just so the pills themselves are bright orange. Let me see, I can pull up that. It's these guys here. And so people are always worried that it's blood, and I will always make sure I tell anyone before I put them on this that this is going to happen. Otherwise, they will call me the next day and be like, Dr. Holland, it was so nice of you to treat my TB, but I think you're killing me because everything is bleeding. It is just something in the pill itself. It is not anything that your body is producing. Because as soon as you stop it, you stop having cool, glowing bodily secretions. I'll leave it there before I embarrass my family even more.
And I'm sure that there's a lot of science people in the chat on YouTube who knew that already. But for those of us who are not science people, I just wanted to know why it glows, Maybe people were too afraid to ask. We do have a lot of actually good questions, though. So the first one I'm going to bring is, do we know how long someone will typically be around someone with active TB before they become infected? And on a related note, about how many other people does someone with active TB typically infect? Kate's going like, I don't know, a couple.
Well, I'm just going like, because there can be so many factors, right? It can depend. Like, I didn't really infect, to my knowledge, anyone that was close to me. And then we have other people that tend to infect a lot. So, I mean, I think the jury's still kind of out. It's just another reason why we need more money and funds for TB research. Because I think there's a couple different factors that can, depending on your work environment, you work in an area that's closed, just like how any other kind of, and certain people, for whatever reason, just wind up being better spreaders. Clearly I don't know if it's the strain, because I mean, I got my strain from this, someone else, but wasn't really a great passer. So, it doesn't, I mean, I would defer to the public health experts on the call, like maybe Amy, but I would say I think the jury's still exactly out, and it can really vary on like the situation. Like,
probably depends on if you've got a lot of friends too. So I'd be fine.
So Kate is exactly right. It depends on your environment. The closer you are in an environment with someone with infectious TB disease, the higher the risk. So when you think about ventilation, if there's not a lot of ventilation, that germ is or that bacteria is circulating a lot more. And CDC actually does publish contact investigation rates, and so it's always a couple of years in arrear. So we can look at that data online to see that on average, and I'm throwing this out there, but from previous looks at it, about 13 to 18 people potentially could get tested as a result of a contact investigation. And again, just like Kate said, it really depends on how sick the person is and capable of spreading the germ.
Yeah, like that kind of gets to, Amy, into that whole thing of like when, how, as the disease progresses in your body, and that's why it's so important to get diagnosed as soon as possible. It it can multiply, right? If you have active disease. So then as you become like kind of more, as the disease progresses, you could potentially become more infectious, right, Amy? Like you could have more bacteria in your body that's coming out when you cough potentially.
Absolutely. And the sooner you get on medications, the rapidly that infectiousness decreases.
Yeah, we heard some really great statistics in our last talk about that too, about how as soon as you get people on medication, that infection rate just drops down immediately. We have a bunch of great questions about testing in here as well. And that is something that we know a bit about here at TB Fighters. So this question is from Connor, and he says, I feel like in TB Fighters, we don't hear so much about IGRA or IGRA. I also want to know if there's two big parties of arguing which is the right pronunciation on that, like GIF and JIF. So we don't hear about IGRA a lot. Is it less common in low resource settings, or is it just that we as a group have been very focused on Gene Expert, and so IGRA hasn't come up very much?
So that's actually a very good question. The Gene Expert is testing on sputum or potentially other respiratory samples, such as bronchoscopies, when you think someone has active tuberculosis, because what that is looking at is the extraction of DNA of TB. On the front end, the TB screening test, the IGRA, I prefer to call IGRA, the quantiferon TB gold, QFT, also is another term, or T-spot, that is used to test the presence of the TB bacteria in the body. So similar to a skin test, the blood test can be used. You may not hear about it a lot. It is a more costly option, but in public health, we use it quite frequently. It's especially important if you've got someone who has a history of a BCG vaccination, because it overlooks that. It doesn't give you a false positive result. And it is also, if you're doing, like in our state, when we do large scale contact investigations with a single visit, and it can, we can get those tests done rapidly.
Yeah, and I remember you also said that one has to be processed relatively quickly after the sample is collected, right? Like 8 to 30 hours, I think it was. So that must also make it very difficult in developing areas and some of the TB hotspots around the world. So yeah, thank you. And IGRA, I will join the correct group on this one. I don't want to be, the odd man out. They'll know I don't go here. The other question on that is, why can't we get Gene Expert Ultra here, and what makes it Ultra?
Well, I can talk about that a little bit, if that's okay. So what's so great about this is that it gets the TB DNA, so you don't need to have the microscope, the stand, the glow in the dark, and it's very quick. But what makes it the Ultra is the fact that it'll give us very quickly the resistance testing. So we often, it's important to understand that drug resistance doesn't just happen because I took it and then it didn't work in me. It can be transmitted. I can catch tuberculosis that's already resistant.
Right.
And it's very important to identify resistance very quickly. And so the Ultra can give us the sensitivity or the lack of resistance to our two big workhorse drugs, the isoniazid and the rifampin, right away. And what is challenging, the reason why we can't get it here is because of licensing. Any device that has to get approved for use in the United States needs to have testing done here in the United States by the FDA. There is not enough perceived money or demand for these tests in the United States to make it worthwhile. I will tell you, there are very smart, very caring people, some of whom are on this call and in groups that are on this call, trying to work to make this better, because we want this to be available to any person. Any place could benefit from a quick diagnosis and a quick resistance assessment from this. But it is, so we're working on this, but it is a licensing FDA issue.
We are quite familiar with some of the pieces about Gene Expert, but Donna, I see you're coming off mute, so I'd love to hear more from you as well.
Yeah, no, I would just say, I think, we in the United States are incredibly vulnerable in a lot of areas, certainly with the sole manufacturing of some of these very old drugs that Kelly still has the picture up on, and but also with the perceived lack of revenue that could be generated. People are not willing to come to the United States, and it's certainly true of drug manufacturers as well as the companies that are making the Gene Expert. What we're very concerned about here in the United States is right now we are the only group that still has just the Gene Expert. And while Cepheid has made a commitment to stay in the market so that we at least have that available, it's not the best test, right? I mean, we want the Ultra here, and we want the latest and the greatest. And so at some point, that vulnerability could also result in us even not having access to the test we do have. So there's a lot of room for advocacy around this particular issue. And so maybe we can follow up with a specific session on that, Tori, at some future
we would
point.
love to. We're very familiar with Cepheid and with Gene Expert in the terms of global health, but I actually don't know how much we've talked about it domestically in the past. So this is a new angle for me, at least, on this. But on a similar theme, how do we build systems where better diagnostics and treatments are existent, affordable, and accessible? Because we've raised all of these great things about the Gene Expert tests, but also that they don't work for pediatrics appropriately and things like that. They're still, even how good they are, they're not good enough. So what do we do as advocates and as just people who care about this? And how do we fix it?
I'll start off. I mean, I think that right now the whole TB community is in quite an odd space around those very questions, Tori. I think some very brilliant people are trying to crack this, and we don't yet have a good answer. It's incredibly complex. I know that there are some possibilities around some FDA waivers or incentivizing manufacturers to come to the United States. But there's also, as Kelly mentioned, there are requirements around the kind of studies that are done, and we just don't have the numbers here in the US. So one option we've explored is, could we get studies that have been done elsewhere where there is larger numbers of TB patients? Could those be submitted in lieu of studies that are actually performed here in the United States? But there's a lot of talk, and I hope that you will join the next call that you've got planned, the one on R&D, because some of the people in TB Alliance are thinking very, very seriously about how we penetrate, at least on the TB drug front, and how we bring some of those drugs that we know are available globally, including fixed dose combinations, dispersibles for pediatrics. We don't have access to that. And so some of our TB physicians will say, we are now practicing outside of the scope of international guidelines because we don't have access to what it is that the rest of the world has.
Yeah, we've heard about people complaining that we don't even have the pediatric medications that taste good. And they don't even taste that good, but they're slightly less gross. So, it seems like something that we should have access to. We have a lot of questions on, that same note of, what can we do as advocates? What can we do to help the U.S. public health workforce? And I think a lot of that is covered in our advocacy trainings, and will be again next week. But one of the questions that I think is a really good one, hey, we don't know how drug pricing works. Why did a manufacturing change cause the price to go up so much? How is that okay?
Donna, I would totally defer to you on why that is, but I know that a big part of it is because, again, it's kind of this like inter-bureaucratic thing where there's only certain manufacturers get like the okay to make the drug, and we can only get them from certain, in the United States we can only use certain, there's just not a market like kind of there to, I mean, Donna, do you mind doing this? Because you'd be so much better at this.
Well, no, I think that, I mean, the complexity of this is huge, right? I mean, and so not only do we have sole manufacturers of many of these generic drugs, but as a new company comes into the market, we get a lot, public health buys a lot of our drugs through 340B pricing, and we are so grateful that we have that. But you have to put in an application. And so new manufacturers can create a new NDC or a national drug code, price the med higher. And then there is some auto correction that happens within the 340B pricing about 6 months in. But I think some of the fluctuation that we were seeing is the high price of a new manufacturer coming in without having approval for 340B pricing. When you saw that really high spike, it came back down once that happened, but then enter a new manufacturer and same thing. Hopefully we'll see it come down a little bit more over time. But this right now is one of the huge issues that our programs are facing. And Amy, you can speak exactly as the program manager what that's doing to your budget. We can't use federal dollars at all to purchase drugs, so that's all coming from state-supported general revenue. And the price of INH alone is potentially going to be devastating for TB programs. But Amy, certainly jump in.
Yeah, Donna, thank you for that. I would say it has been extremely detrimental. As Donna shared, we cannot use our federal funding for that. It completely comes out of state dollars. It's hard for us to budget appropriately. We can't predict our case rates. In South Carolina, we treat both disease and latent TB infection, but we've had to critically look at how does this look on the landscape when disease is our priority for treatment. How does that look on the LTBI landscape? And we never like to, have to make decisions like that.
And I think Kelly, go ahead.
Oh, I was just going to say, as a final note to Tori's initial comment, how is this okay? I will just quickly add, it is not.
That's what I figured. And it also is one of those things that I feel like is so complicated that people are just like, well, that's how much that cost. It's like the game of roulette. Every time I go to pick up my EpiPen, I was like, how much does it cost this year? There's no way to know. And I don't get any say in that. I just have to not have an allergic reaction.
But one of the things that I think, we don't yet have TB meds on the essential medicines list here in the United States. So there's been a lot of activity. I think there's room for advocacy around that, Tori, is really pushing to make sure that some of these public health medications are on the essential list, that's a priority for manufacturers. We've even had some people say that when it is a public health disease such as TB, all of the drugs should be provided, and that the federal government should step in and try and do some cost adjustments based on that. So again, nothing we've tried yet has worked, but a lot of people are really putting a lot of energy into thinking about what we could do to make a difference.
Yeah. And let us know if there, if and when those things need advocates. I think that this is a group of people who really care about this. And if we have to go state by state, then we'll go state by state. Connecticut's a small state. I can go argue with them right now. It takes 45 minutes to get there. I guess they're probably not working. But
I also just want to say real quickly, like while we're all mad about this, that like a lot of these, a lot of developments in tuberculosis that we don't have access to in the United States were partially paid for by U.S. tax dollars. Like some of the research and some of the things that go into it, and so I'm proud that U.S. taxpayer dollars go to any treatment that makes anybody healthier. I really am, and any diagnostic that is what I want it to go to, right? But it'd be great if we could use it too, so it's just kind of like very, very strange, like that whole cycle, so, I really do think, like we should get to use it, and so it's just really nuts. Just really nuts.
We're mad about this 100% of the time over here. So we're always happy to.
Well, and we've had actually people say that right now the worst place to be diagnosed with TB is the United States.
Yeah.
And that's just horrible. I mean, as Kelly said, that is not okay.
Yeah. And I think that, I feel like I'm in a very lucky position where I probably know a guy, but most people, probably their physicians have never even seen active TB. So that doesn't seem like the great situation to be in. So while we've got some great public health professionals in here as well, we have a question in the chat, because it seems like public health is a backbone to all of this. That's very, very clear. How does one get started in a career in public health initiatives related to infectious disease? This person has a background in biomedical science and is interested in transitioning to public health. But what do some of those jobs look like? What does that work look like, and how can people do it?
I guess that question is for me as the public health expert, right? How do you do it? I went into this career. I'm a nurse by training. Did a rotation through public health, was fascinated by meeting people where they are. And within TB, for me, has been personally refreshing. I've been in TB services since 2008, started as a frontline TB nurse and has, became a regional manager and then the state director. It's the long-term care for a patient, and seeing them from illness to wellness has been so gratifying. But within public health, there's so many jobs that, not only nursing, there's epidemiological roles, there's, even within our TB program, our caseworkers going out and assisting, and in the STD role, the DIS worker going out. So there's many job opportunities, and happy to talk to anybody who's interested in public health.
Yeah. And that is one of those things that we're trying to figure out how to learn more about, of like, there are so many people that we get to meet and interact with in this world of TB. What was everyone's job? I feel like I ask my friends that all the time too, though, because it's like, I don't really know what anyone does as a job. But this is definitely something that we love hearing about and love learning more about. I think that we've got time for probably like 2 more questions. One of them is, I think, one that's probably going to be addressed in our next training, but would love to hear from you on this. Are there any new studies on the horizon for treatment or diagnostics that you guys are particularly excited about, that look promising? Anything that to look out for?
I know that, like, and again, this is totally going to be covered in the next one. So, but there's still a lot of like really promising vaccine stuff that probably just like really makes me so excited. And the diagnostic stuff, like there's a bunch, like with like poop and pee, which are just really great. Again, like Kelly, as someone who treated like, children, like, like it can be really hard to get, samples.
Yeah, we've heard about that.
Yeah, and they poop and pee like you don't even want it. So like it's so great. They can take they can do something good with it. It's like it's so great. And so those are really great, and just being able to. So for those things are really cool, and also just diagnostics where you don't need like a whole lab, like kind of remote stuff. That's really cool. That stuff is really exciting. And there's a lot of cool studies, not just on new medications, but also like taking medications for shorter amounts of time, so the side effects are better and more manageable. That stuff really makes me excited. I think that kind of the lengths we treat people. I think that if they can be shorter, like that would be really great, because not only would it make the person who's taking the medications like have less side effects and be under the situation, where they're kind of being monitored and stuff for so long, but it would also be an ease on programs. So it just, if we can make these things shorter, like it's so great. So those are some things I'm excited about. But you will hear about them.
Yes. And I will say that I have heard some people say that what they had originally thought at some point was science fiction is about to become reality. I mean, we were talking about point of care testing. We're talking about maybe TB infection treatment that could be one day type of thing. So there is a lot on the horizon that we have to be excited about. Whether it gets to the US, we still have to do some advocacy around those issues. But no, there's a lot of cause for some positivity, I think, Tori, in that space.
Positivity and to keep pushing.
Yes.
Because these things, like, you would not believe how long it can take, like that was the other thing. Like, you test and test and test and test and test, and then, like, just takes so long. Yeah. So again, keep pushing. But, it's so great to see like where the past pushing has gotten us already.
Mm-hmm. Yeah, and I would just say, Kate, on that point, multi-drug resistant tuberculosis and extensively drug resistant tuberculosis, you will meet some of our We Are TB colleagues who were getting injections for a year and a half, for 2 years, whose lives are taken over, people who lose their hearing, who have terrible pain in their nerves because of these old regimens. And because of this research, now the regimens are 6 months, and these are accepted around the world because of new drugs. So those things in the future are so exciting, and also great things have already happened because of these dedicated people doing these studies. So hope out there in the future, also hope that's here now. But as Kate said, we just gotta keep pushing. And
Amy, do you have any that you want to add before I tune to our last question?
I'll wait for the last question.
All right. The last question, I feel like you guys already spoiled your answers a little bit because I didn't warn you, but we always ask the same question at the end of our TB live streams, because here at TB Fighters, we are very, very big on the concept of hope. It is so easy with literally everything happening, especially in the US right now, to fall into that place of despair. And that's not a useful place to be for anyone. So we always like to ask, what are some things giving you hope right now, and what's kind of keeping everyone going through this? So I'm going to start with Amy.
I was coming off of mute. I was wanting to be the first to speak. Hope in me every day is seeing that person being so ill and becoming well again. That is hopeful for me, and knowing that we can treat and cure TB.
I will say hope for me is being on a webinar of people who want to spend their Monday evening learning about a disease that they never had, and wanting to go and make sure that people they've never met will not die from it.
I applaud that answer, Kelly. I would say hope for me is the conversations that I'm hearing about that are now happening with much greater frequency between are patients and providers. And I think part of what we've heard is that this whole focus on shortening isolation and trying to get people back into the routine of their lives more quickly has opened up a real desire to better understand what it's like for that patient, what it's like for their family. So these conversations that are truly patient-centered are extending well beyond what we used to see. Do you want a longer course of treatment that has fewer side effects? This is partly so these conversations are starting to give me hope that people are engaging and really better understanding those of the people that are most experiencing the impact of tuberculosis.
Kate, you're gonna make me cry.
I'm like, this is like, I did so good. We're like, we're past 9:00. Like,
Because he's trying to
oh my God, I turned my video. I don't know. It's like, it's definitely like a combination between what Kelly said and what Amy said and what Donna said too. Like it's so gratifying in our support groups to see people come to us needing support and, coming and then ending up being advocates and staying on the calls to help other people. And so that's what, for right now, just everything, right? It's just like, sum it up as everything, sometimes I feel really bleak, but I know if I just make it to Monday, I'm going to be okay. And Kelly's right. I can't even tell you enough, how many times Kelly and I, with people like Donna's support, have told our stories, just into this kind of an abyss, you know what I mean? And just last year, when there was so many people there and this kind of groundswell of public support that we've just been looking for so long, it's just so incredible. What's happened is so incredible. And how can you not feel hope? How can you not? I don't know. So that's it. It's I feel like it's the cop-out answer because everybody said everything what kind of the same things, but it's really everybody on this call and everybody watching on YouTube and what a beautiful space it is. No one has ever been interested in TB for the money. It's all to help people. And so it's people like Amy that go into this career too. I've just met the most beautiful people doing this stuff. And it's just so good.
Yeah, and I mean, we're just so grateful to have been welcomed into this space with all of you as well, and that you're able to kind of just teach us how to be good advocates here and everything that we don't know. I can't express how grateful all of us are for kind of a bunch of weird people showed up at your cause and you welcomed us right in. And, that can't be overstated because I think that between us as a group, there's just kind of this confidence that in our lifetimes, we will be able to switch to saying TB was the world's most deadly infectious disease, and it's not anymore. And we can't do that without the incredible people teaching us how to do that. And I think that is a little bit where hope is on our end too. So, or at least on my end, I can't speak for everyone, but so grateful for all of that. And now I've just switched to the boring part of announcements really quickly. So in case people missed it at the beginning, Kate, can you please remind us about how people can get in touch with We Are TB and find your support groups?
Yes. And thank you so much for asking. So, just so you guys all know, if you go to wearetb.com, you can also go to a direct one, that's wearetb.com/patient support. And that will take you directly to that form. And when that form happens, literally when you respond to it, I get a little thing on my phone. So it's just going to me. I'm going to read it. I'm going to open it. And I'm going to send you an email. And then I will invite you to our support groups. So it's not a bunch of people see it. It's, when I get your permission, I'll add you to our Google group and then you'll get our emails. And that's really just it. And then it's just it's very much like this. It's like a Zoom call. And we're all talking a lot about TB and we're all being very open. And a lot of times we're talking about stuff that's nothing to do with TB and, and it's just a community. And so if anybody on this call has TB, someone in their family has TB, a loved one has TB, you're about to take a medication and they're telling you got to take a TB test and it makes you nervous, or you get the results and you want to start a biologic of some sort and, you're nervous because they're saying you have latent TB, you're not sure about the treatment, regimen, if you want to take it or not, you want to ask people who know, please come on the call. You don't have to you can just be on mute with the black screen the whole time. We'll take you any way we can get you, and we're very happy for your interest.
I think of all the things we shared tonight, that's up there with one of the most important ones. And so thank you for giving us all of that info. And we'll make sure that all of the links are in the description of this live stream and available in all of our other ones as well. Less important announcements from our end. So tomorrow, February 10th, around noon, voting for the Project for Awesome opens. So for anyone not familiar, the Project for Awesome is an annual charity live stream event run by John and Hank Green. And since it's been started, it's raised about $20 million for charity. And each year, half of what is raised is split between Partners in Health and Save the Children. And the other half is divided up between organizations that our community votes on. The 20 million, by the way, is total, not any given year. Just want to clarify that one before everyone got excited. So the remaining half of that money that is raised is divided up, and people make videos to nominate charities and causes that they care about, and our community votes for them, and voting for that opens tomorrow. And if you take a look, you might see some familiar faces and some familiar videos on there. There are a few TB-related organizations that have been nominated this year by our community. So if you go to projectforawesome.com tomorrow afternoon, you'll be able to log in and perhaps vote for them if that's something that resonates with you. We also encourage you guys to just join in on the live stream that's going to run from like noon on Friday through noon on Sunday. It's not full 48 hours anymore because we've all grown up a little bit and can't stay awake that long. But there's going to be really great content ranging from like really heartwarming things with, Joya from PIH and someone from Save the Children to very, very strange combinations of food and a lot of just general silliness. So you hear charity live stream, you think Sarah McLachlan. This is the opposite of that vibe. It's like not just sad pictures and people doing stuff. It is just a really fun community event. So we are opting to, you've welcomed us into your community. We are more than welcome into ours, but ours is a little bit strange sometimes. So voting goes through, I think, later in February, but take a look at that for projectforawesome.com. And speaking of Project for Awesome, you might have seen that TB Fighters has released some TB merch, but I guess it's anti-TB merch. I still have not figured out how we're saying that. With our friends at DFTBA, somebody's going to put the link in the chat for that as well. If you're coming to Hill Day and you want to wear your TB shirt to training, you need to order that before Friday if you want to get it in time without the expedited shipping. So you'll still probably be able to get it there in time if you choose rush shipping, but that's expensive. It's not mandatory for Hill Day or anything like that, but it is a really cool design. So just wanted to share that one as well since we're running out of time on that. And finally, next week on February 19th, that's a Thursday at 8 p.m., you might have heard us talk about it, but we're having another special edition live training, this time on TB innovations and breakthroughs. That's going to be brought to you by our friends at TAG, IAVI, and TB Alliance. And I think that is everything from us. So if I forgot something else, I'm sure we'll email you about it. So as they say in our hometown, don't forget to be awesome.